providing high-quality radiology education to all the radiology colleagues worldwide. Was established in October 2021 and based at the Department of Radiology at Wake Forest University School of Medicine. It offers free online education resources and live webinars featuring academic radiologists from leading US institutions. The program is designed to bridge education gaps, particularly for radiologists in resource-limited settings, by sharing expertise and fostering global collaboration. We host bi-monthly webinars from January to October, covering various radiology subspecialties. The sessions are well attended with up to 400 to 700 participants per live event and include contributions from esteemed institutions. AREP's reach extends to radiologists in different countries in Asia, Africa, and Middle East. The program's success is driven by the dedication of its committees, moderators, and speakers who work tirelessly without external funding. In addition to webinars, AREP offers projects like the Radiology Excellency Program, which focus on mentoring and specializing radiology challenges in various countries. So again, I welcome you all for such a wonderful session, which is going to be on an abdominal imaging on MRI rectal cancer staging baseline. And today's moderator is Dr. Mohammed Warfa, and he's a great friend of mine. He's also a consultant of molecular imaging and adult radiology in Sidra Hospital in Doha, in Qatar. All right, over to you, Dr. Warfa.
Thank you very much. Thank you for inviting me to this lecture. I would like to introduce, it's my honor to introduce Dr. Niraj Lalwani. He is a highly esteemed professor of radiology at Virginia Commonwealth University School of Medicine. And he was also my professor when I was a fellow in Wake Forest. He has an extensive background in abdominal imaging, particularly gastrointestinal and GU radiology. And he has extensive contributions in clinical practice and academic work. Currently, he's the editor-in-chief of a very prestigious journal, Abdominal Radiology, and he has extensive expertise in abdominal and pelvic MRI, in particular with staging rectal cancer and also MR defecography. He has a very impressive amount of publications and presentations, and he's actually one of the people referred to within these fields. He has multiple awards, including the Honored Educator Award from RSNA and the Figley Fellowship Award from the ARRS, the American Röntgen Ray Society. He is a mentor. He has mentored me and JP also, many other students and medical students, residents, and fellows in research. And he's dedicated to fostering the next generation of radiologists. As you can see today, he's giving us this lecture and teaching us today. So please join me in welcoming Dr. Niraj Lalwani.
Thank you, Mohammed. I'm really honored to have you here, and thank you for your kind words. My mentorship is always there for everybody. As I said earlier, there should be no boundaries for anybody to learn. We all, those have the opportunity to learn from Western world, should pass this knowledge to the other part of the world. And I personally came from that different part of the world, so I know how it feels. I'm really honored to be here, and I'm going to share what I know about this particular subject to all the attendees from different part of the world. And I hope it's going to help the patients, help the people there to give better patient care to everybody. Okay, let's start here. So it's MR rectal cancer staging. I'm talking about just the baseline today, and I'm just going to talk about rectal cancer because it can be sometime low rectal or recurrences, or can be mucinous, or can be anal canal. So those are different things, all different things. So I'm not going to cover those extensive things. And after the treatment, the interpretation is a bit different. So I'm just going to focus just on the basic thing, like a baseline MR rectal cancer staging, because that is something we should all know. And this all started like almost 2 decades back. 2010, I would say it came into limelight. There was nobody knowing this particular topic in US. Fortunately, I had some chance to work with some people in Europe, which those were doing it, and I learned from there, brought it here. I was one of the few pioneers who brought it to the US, and then it became very famous afterwards. And now it is part of the routine practice. So let's start. So before I proceed, I need to put some disclosure here. I am an author with Elsevier, which is the book I'm showing on the left side. All this content which I'm going to talk about is already there in that book as well. I'm a speaker for MRI Online. I have few of the courses there on pancreas, MRT radiography, and few other subjects on that website. What are our learning objectives? So we are going to learn, first of all, what is mesorectum? What does this term mesorectum mean? And how it appears on MR. And then comes what are the practical implications of this radiological anatomy for staging purposes, which can help the patient and the clinician to tailor a specific management. And then we have to talk about what are the different staging, and then we will review some of the selected cases as well afterwards to give you kind of hands-on training here. I mean, I wish I can interact with you through some kind of polls or something, but which I cannot do here. Hopefully in future I would be able to do that. So let's start with the anatomy, basic anatomy. I mean, anatomy is so critical for any subject, any topic in radiology. And if we go back our first year of medical school, rectum, how long the rectum and how long the anal canal is, we were classically told that anal canal is just less than 3, 2.5. But and then we talk about the rectum, it is about 13 centimeter. But the point is, for the purposes of MR, we take rectum as 15 centimeter. Why we do that? Because we are including the lower portion of the anal canal into the along with the rectum itself. So what we do basically, we start from the lower portion of the anal verge, which is the lowermost margin of the skin, where you have the change from squamous to the anal canal kind of mucosa there. And then from there, from the anal verge, you measure the 15 centimeter. That's going to be the rectum on MR. Why we are doing, as I said, we are including the lower portion of the anal canal into that, because sometime you can have a tumor in the lower rectum involving the anal canal, which is called as anorectal tumor. Or sometimes the anal canal tumor can go and involve the rectum. So both are possible. So if you have a tumor inside the anal canal, that will be usually squamous cell carcinoma. But once you have the tumor inside the rectum, that will be adenocarcinoma. So it is before we start doing rectal cancer staging, it is very, very critical to know what kind of histology it is. If it is a histology of adenocarcinoma, that will be a lower rectal cancer which has involved the anal canal. If it is squamous cell, then it is anal canal tumor which has involved the rectum. So there are both different things. Remember, those have different staging system, different treatment system, different way of behavior, and different way of upstaging how they involve the neighboring structure. So don't going into that detail for now, at least. Let's talk about the 15 centimeter we were talking about. So if we take that 15 centimeter and divide into 3 equal parts, every 5 centimeter will be called as lower, mid, and upper rectum. So anything more than 10 centimeter or higher will be upper rectum. Anything in between that will be 5 to 10 centimeter middle rectum, and below that it will be lower rectum. Why they are important? Because they have different kind of blood supply. Why blood supply is important? Because it will determine where the lymph node will be situated. So if you have arterial supply from the superior rectal artery, which is a continuation of inferior mesenteric artery, that is going to supply the upper rectum. But the middle and inferior rectal arteries are going to supply the mid and lower rectum, which are the branches of internal iliac arteries. So based on this artery, we know that if we have mid or lower rectal tumor, that is going to drain inside the internal iliac artery region. And if we have upper rectal tumor, it's going to drain into the region of internal inferior mesenteric artery or superior rectal artery. And this is how you determine the location of the lymph nodes. And then based on the territory, you can determine whether that lymph node is situated in the anticipated drainage or not. If the lymph node is situated in the anticipated drainage of the artery, you are good. But if it is not, that means it is basically a metastatic disease beyond the region of drainage. and that will upstage the tumor to M1. And we will talk about this later on. Okay, so let's move forward. So now we have talked about 15 centimeter of the rectum, but the point is how you can tell just by seeing on MR what's the rectal extent, from where to where it extends exactly. So this is a kind of tough question and nobody has the perfect answer, but I will try to answer it. So if we talk about the rectosigmoid junction, anatomically it is S3 vertebra, but on MR there is nothing anatomical. Everything is surgical because we are talking about our customers. Our customers are surgeons. We have to satisfy them and help them to perform the best possible surgery and treatment for those patients they are dealing with. The stakes are high. So sacral promontory is going to be our landmark to determine rectosigmoid junction. Anything above that will be called as sigmoid colon. What is anorectal junction? Anatomically, it is dentate line, but we don't even see that on MR. Surgically, it is anorectal ring. And what is that? It is basically a ring formed by the muscles. Basically, you have pubirectalis muscle, which is coming backwards and joining or forming a sling along the backside of the rectum and joining the fibers of the levator ani muscle or external sphincter. That is anorectal junction. What about the peritoneal covering? Is the entire rectum covered by the peritoneum? No. Just the upper two-thirds is covered by the peritoneum, and specifically upper one-third is anterior and lateral aspect, middle one-third is just the anterior aspect, and just the lower rectum, just lower one-third is extraperitoneal completely. So this is a very critical concept to understand. That means the posterior part of the rectum in upper two-thirds is not covered by the peritoneum, and there you can have presence of the fat, which is the fat surrounding the rectum, and that's what we call is mesorectum. Anal what we talked about, lowermost edge of the anal canal. And dentate line we don't see on MR, but just to know that it is a watershed between the rectum and anal canal, it is about 1 to 2 centimeter above the anal verge. Okay, so let's move and give you a quick idea. What are the relationship of different organs in the sagittal plane? If we take a mid-sagittal plane through the pelvis, where you can see the sacrum and the coccyx and pubic symphysis, this is how it's going to look. So on the back side, we have a fascia covering the bone, a fascia covering the rectum, and the space in between is called as presacral space. From coccyx, you have some of the muscular fiber joining here, which is anacoccygeal. Some of the fibers here go and join together to form a levator plate, actually, which joins with the levator ani to form a conjoined tendon. And this is the anal verge, lowermost portion of the anal canal. Dentate line we don't see. Then you have rectal walls. Those are kind of formed by the mucosal folds itself. And here, the most critical thing, along with the anterior aspect of the rectum, you can see a lining, which is actually peritoneal reflection that goes on the top of that. As I said, upper two-thirds of anterior and upper one-third is just anterior and lateral, goes anterior to the rectum, passes on the top of the dome of the bladder, and then goes along with the anterior abdominal wall. In between the two, rectum and the bladder, you have this thick fascia, which is called as Dunning-Weller fascia. This is so critical in the male patients because it contains the hypogastric nerves, which is responsible for erection. So if you're going to damage this fascia, you're going to compromise patient's sexual life. So that is also critical. So surgeons want to preserve this particular fascia because they want to keep the patient's life, you can say, quality of life intact. So this is how the mid-sagittal plane looks. And then we talk about urogenital diaphragm, urethra. That is not important for rectal cancer staging purposes, but you should know how they look on MR. And this is the concept I was talking about. Lateral and anterior one-third, upper one-third has anterior and lateral aspect of the peritoneal covering. Middle one-third has just the anterior aspect, and lower one-third is not covered by the peritoneum. And this entire area here is surrounded by the fat throughout the length of the rectum. Presacral space is critical again because if you have posterior wall rectal cancer, it's going to invade the structure in front of the bone. And usually here you see some of the vessels, some tiny T2 weighted hypointense foci throughout this area are actually vessels, presacral vessels. So if you have the tumor, and if you don't see that vessel's there, that means the tumor has invaded that vessel. And invasion of the presacral fascia is in a kind of upstaging. It is beyond the mesorectal fascia. Why it is beyond? Because it is surrounded by the mesorectal fascia anteriorly. Posteriorly, it is presacral fascia. So if the tumor has gone and involved this space, that means it is already beyond mesorectal fascia. That is compromising the mesorectal fascia. And how the fascia looks, fascia, I will show you those images afterwards. And those hypointense linear tiny structures, presacral vessels, are very critical to see on the axial and sagittal plane both. We talked about dental fascia. It is not, in female, it is replaced by rectovaginal fascia. In male, it is called as dental fascia. Yes, this is very critical. So once we go to the axial plane in the upper 1/3 of the rectum, we have to determine where the margin of the peritoneum is. And this is determined by this particular sign, the wing-like sign of Sigel sign. We see it is like kind of wing formed here in front of the rectum. And that is the determination of the extent of the peritoneum. This is how we can find the peritoneum. And finding peritoneum is so critical because it is going to change the complete grading and staging of the tumor if the tumor is involving the peritoneum. It is going to significantly upstage the tumor, even though if it is early tumor. So now the concept of the mesorectum. What is mesorectum? Mesorectum is basically an enclosed space which is surrounded by mesorectal fascia, which extends from the top of the peritoneal reflection. That is how the peritoneal reflection is so important. From there all the way down up to the insertion of the levator ani muscle with the external sphincter. So this entire space is mesorectum, which is surrounded by a fascia, and the fascia always looks T2-weighted hypointense, a linear line which is surrounding the rectum and enclosing the space which contains mostly the fat. But it is not the fat actually. In addition of that, there are vessels, there are lymph nodes, rectum is there, seresa is there, peritoneum is there basically. So this is the entire enclosed space we talked about. And as I said earlier, this entire space seen throughout the circumference of the rectum is only seen in the lower part, lower 1/3. In the middle and upper 1/3, anterior portion is covered by the peritoneum. So you are missing the complete mesorectal space anteriorly in upper 2/3. That is also important because as we go downwards, we can see the thickness of the space is decreasing as we go towards the levator ani muscle. The space surrounding the fat surrounding the rectum is decreasing. And then why it is important? Because if the tumor occurs anteriorly and the space is very low here, if it is just few millimeters, it's going to invade the mesorectal fascia or the structures anteriorly, including the dental fascia or submaxillary vesicle. So even a small tumor can invade these structures so early if the tumor is situated in the lower 1/3. That's why the lower 1/3 tumor are so different and taken so seriously by the surgeons because it will undergo different surgery altogether. If the tumor is invading the levator ani or external sphincter or pubic muscle, that will be you can say abdominoperineal resection. It's kind of a different, very advanced kind of very aggressive kind of surgery where you have to compromise patient's life quality because they will be living on colostomy forever for entire life because they cannot save these sphincters. If they save the sphincter, that will compromise the treatment and there will be more recurrences after that. I will show you that how it looks. So now we know the concept of mesorectum. It is an enclosed space. It is enclosed by the mesorectal fascia, which forms a natural boundary to the tumor. It has the rectum, fat, lymphatics, nodes, and draining vessels inside the space. So now, just looking on this concept, you can think surgically. If you resect this entire enclosed space along with the tumor, the chances of recurrences are going to be low. Simple. Because you have removed everything, including the nodes and the vessels and rectum all together with the tumor, with the facial boundary, which is naturally there. So now the chances of recurrences are low. That's how the total mesorectal excision is so important and so, you can say, successful surgery for these patients. So en bloc excision of mesorectum has less chances of cell spillage and residual tumor and recurrences. That is why the TME is so critical. And what is this term circumferential resection margin? We see this a lot in our pathological reports. This is actually a pathological term. It is determined only after the surgery has been done. Sample has been taken by surgery and it has been sent to the pathology, and then they will determine if the circumferential resection margin is intact or not. In reality, this is pathological term, but it corresponds to mesorectal fascia on surgical sample or radiology as well. So we can interchange these terms on our reports. If you say the CRM is intact, that means you're saying the mesorectal fascia is intact. Okay, and seeing an intact mesorectal fascia is a very good news for everybody, because that will have complete excision of mesorectum and less chances of residual tumor or recurrences. This is how it looks on MR. Now let's see all different planes. On axial plane, this is how it looks. A thin linear T2-weighted hypointense line surrounding the entire rectum is actually mesorectum. This was the perisectal space I was talking about. And then anteriorly, there is very little space, but we can see another fascia in between, that is denonular fascia. Seminal vesicle is situated just anterior to that. See, the space anteriorly is much lesser compared to the space laterally or posteriorly. If you have a tumor in this location, it's going to involve the mesorectal fascia very quickly. Okay, and if we see the same thing in the coronal plane, from coming from anterior to the posterior aspect, we are close to the sacrum here. We can see this entire mesorectal fascia encircling the rectum, and it goes high up to the peritoneal reflection all the way. This is the mesorectum seen on MR. And as I said, as we go downwards, the space becomes smaller in this location because it is very close to the levator and muscle. This is the levator and muscle. These are different portion of the anal sphincter. There are three portions like subcutaneous, superficial, deep. So these are three components of the external sphincter, but they merge together along with the levator ani muscle, and this is the anorectal junction where you have a sling of pivorectalis muscle passing along with the posterior aspect and encircling it. And that is the only muscle actually in our control. If you want to hold the stool, you're going to contract the pivorectalis muscle. That is how it is called as anorectal junction, because we are trying to increase the angulation there to hold the stool inside. And this is how it looks posteriorly. And as we go posteriorly, levator ani is going to join together to form like a conjoined tendon, which is called as levator plate. So now, how you can find the peritoneal reflection in male and female patients? In male, it's actually very, very stable location. If you just pick up the tip of the seminal vesicle, it will be usually just superior to that. In female patient, it's highly variable, but you have to take a landmark of uterocervical junction to find the peritoneal reflection. And this is how it looks at MR. As we go to the superior part of the seminal vesicle, the tip, and you can see this black line, it is the peritoneal reflection. If you have the tumor here, it's going to involve reflection quickly, and that will upgrade the tumor. The same thing in female. We are at the cervico-uterine junction. This black line is showing you the peritoneal reflection. And we talked about this earlier, just to repeat that lower 5 centimeter, basically lower portion of the rectum is going to be completely encircled by the mesorectum. And this is how the peritoneal reflection comes and goes deeper. So any tumor in this location is going to involve the peritoneum very quickly. So why the involvement of peritoneum is so critical? Because it will cause spread of the tumor earlier. It will lead to metastasis in the liver or the lung. How we do the staging? So nowadays, this concept of N2 versus N1 is gone. People just say N plus. If you have any N, that is an indication of neoadjuvant therapy. But just to know that N1 is about 3 or lesser lymph nodes in the mesorectum, pay attention to that. Mesorectum, just the mesorectum, not outside that. Okay. N2 is more than 3 lymph nodes in the mesorectum. And once the tumor is confined to the submucosa, that is called as T1, which is very difficult to find on MR. not so critical. But once the tumor is gone and involving the submucosa, um, and reaching up to the musculus propria almost, that is T2, but it is not going beyond the musculus propria. Once it goes beyond the musculus propria, it becomes T3 tumor. And once it goes beyond musculus propria, serosa, and involves the neighboring structure, that is called as T4 tumor. So it is easy to understand. For us, these are the most critical things, okay? And finding the N plus disease or not. N1, N2, it's your wish if you want to call them N1, N2, it doesn't matter. But N plus is more important. And this is how you T stage them. Once you have T3 disease, I mean, this kind of more difficult to remember in my opinion. T3 disease to me is good and bad. Any disease which is within 5 millimeter from the surface of the musculus propria is going to be good disease. Anything more than that will be bad disease. Why it is important? Because if you have good disease, you can still do TME if the nodes are not present. If it is a bad disease, you cannot do straight away a TME because you have to treat the patient now with the neoadjuvant chemotherapy first, and then wait until it becomes a low stage disease. It can go anywhere, and then you operate on that patient. Okay. As soon as you have involvement of the peritoneum, that becomes T4A. So you can have a very small tumor anterior aspect of the rectum, like 5 millimeter or lesser, but it can involve the peritoneal reflection very quickly. That means it will upgrade the tumor to T4A. Once you have involvement of an organ, that will be T4B disease. And this is also very critical because I've seen many reports where people call involvement of the organ, but it's actually not there. And sometimes people say it is aborting the organ, there is actually an invasion. How to determine the organ is involved or not? If you have a tumor intensity on T2 weighted images, that is, remember, T2 weighted images are our workhorse. Those are the key images. Those are the mainstay of the entire diagnosis. If you have good quality T2 weighted images, you are good. But if you don't have, you cannot stage it well. And I will show you the protocol as well after this. But the point is, if you have a T2 intensity of the tumor involving the organ, and the intensity is also seen inside the organ itself, that is, a classical T4 disease. But if you see a fat plane between the organ and the tumor, that means the fat plane is maintained and that organ is not involved. What about having no fat plane, but there is no intensity as well inside the organ? That is a potential involvement of the organ. So there might be cellular level involvement, but we are not seeing it on MR. So you can use three terms there: involvement of the organ, potential involvement of the organ, and no involvement of the organ. No means there is a fat plane between the organ and the tumor. So what is the surgeon's point of view? What they want to know, first of all, they want to do the best possible surgery for the patient, that there is no recurrence or residual tumor after the treatment. That is the main goal here. And we have different options for the treatment. It can be local excision if it is an early T1, T2 disease. They can go transanally nowadays. We can do an LAR, low anterior resection, or we can do APR, abdominal peritoneal resection. So abdominal peritoneal resection, as I told you earlier, it's kind of very extensive surgery with the long time stoma. So we have to decide all these surgeries and giving the treatment before and after. Before the surgery is performed, it's called as neoadjuvant therapy. And after the surgery has been performed, it's called as adjuvant therapy. So if we are doing adjuvant therapy after the treatment has been performed, that will be determined how extensive tumor was. So based on our report, they are going to decide what kind of surgery it will be. If they do too conservative surgery, there will be recurrences. If they do too radical or extensive surgery, it's going to compromise lifestyle. As I said, like patient with this APR is going to live with stoma forever. So our goal is to provide a balanced report to them, a best possible report to them, so they can tailor the treatment for the patient, and then do not compromise the quality of the patient, but still provide the best possible treatment. What is our role? Our role is to differentiate whether it is T1/T2, whether it is T3 versus T4. That is the most critical thing we have to recognize. Here it doesn't matter. If you cannot recognize between the two, you're good, because they are going to still treat the patient either transanal resection or give the neoadjuvant and then treat based on the lymph nodes are present or not. This is not important for us, but the important thing for us is basically T3 versus T4. And then again, T3 is good or bad, 5 millimeter or lesser, or 5 millimeter or more, good or bad. That is what they want to know. And once it is T3 disease, we have to talk about good or bad, as I said. And what is the status of the mesorectum? Is it like CRM is spared or not? And how many lymph nodes are there? Is it just the mesorectum which is involved, or it is beyond? If you have lymph node in the location of para-aortic region, or if you have a lymph node beyond the anticipated drainage of the rectal arteries, that is an upgrade of the disease. That is M1 disease. That is not treatable with the mesorectal resection, whatever the stage is. Doesn't matter. Okay, so you have to tell them what is the stage exactly. So this is how it works in North America, and possibly in most of the other part of the world where we have good quality medical care available. Pre-operative approach, they detect the tumor, and that is also important. Detection of the tumor with a biopsy proven results. That is a prerequisite to perform MR rectal cancer staging. If you don't have available histopathology, don't commit on your report that stage. And you can put a disclaimer to begin with in the impression that histopathological diagnosis is not available, presumed tumor. Based on presumed tumor, this is the staging. Because it can happen, there are mimics of certain other inflammatory diseases which can look like cancer, and then you stage them, and actually there was no tumor. So don't fall into that trap. Make sure that surgeon who is referring you knows this fundamental, and they have a biopsy proven result provided to you, and then you can put that biopsy proven adenocarcinoma, whatever, and then you start your report. So they have to perform proctoscopy, colonoscopy, CA level, CT, PET CT, depending on what they have available and how much patient can afford, depending on the insurance coverage. And then they discuss these cases in the multidisciplinary tumor boards, where we have oncologists, surgeon, and radiologist together, and they stage it together and then decide what is the treatment strategy in that particular patient. It is selected based on that discussion whether it will be neoadjuvant chemotherapy or not, radiochemotherapy or not. Any tumor which is BAT T3 or T4 will be going to that direction. Any N CRM positive, as I said, N plus is more important. If the tumor is invading the CRM or mesorectal fascia, that's going to be advanced disease, and they will be extensively treated before they operate on that patient. And these are the different options we talked about for surgical purposes. And then after the treatment has been performed, resection has been performed, they will look on the pathological report and then decide if the patient requires adjuvant therapy or not. Okay, this is how the patients are approached nowadays. And these are the different risks and the treatment options available, are not very important for us, at least at this stage. These are the differences between the APR and LAR. So what happens, here you can see that what is happening, we are dissecting a tumor in the lower sigmoid colon or rectum or rectosigmoid region, and here patient is undergoing permanent colostomy because the tumor was situated way low inside the lower rectum or close to the anal canal. So this entire section of the rectum has been removed along with the anal canal, because this is tumor which is involving the sphincters, and if you leave them, it's going to be recurrent. So they have to reset this entire thing, and this ostomy will be created forever. There is no reversal. This is APR. And then LAR, what is happening here, they're resecting the tumor which is slightly higher in the middle rectum. They're resecting this segment, but they're leaving a portion of the anal canal with the sphincters intact. And later on, once it is healed, they will bring it down and join it together. So initially it will be formed as a J pouch, but later on there will be a reversal surgery, and eventually the patient will have its natural anal canal and the sphincters controlling the functions. So the quality of life versus this is going to be much better. But this is not possible unless you have a mid-rectal an upper rectal tumor. If you have a low rectal tumor, surgeon has to be very smart and trained and experienced to perform those surgeries. And sometimes it is not possible even for them as well. And these are the newer kind of surgeries nowadays available. They can actually go, for example, the tumor has invaded the internal sphincter. What is internal sphincter? Internal sphincter is basically nothing. It's just the rectal wall with the circular and longitudinal muscular fibers. External sphincters are basically the portion of the anal canal, and there is a plane between the two sphincters, internal rectal wall, external anal sphincters. This plane is called as intersphincteric plane. You go in between and then resect the entire tumor and the rectum, and then chances of recurrences are low because the tumor was confined to the rectal wall or the internal sphincters only. Here, there is a involvement of the internal sphincters and the levator ani muscle. So now we have no choices. We go with the extended LAR, and then remove everything together with the levator ani muscle along with the sphincters. I said APR, that was actually correct. So it is basically APR. So they are removing everything together. So now the point is MR versus endoscopic ultrasound. I mean, how they compare together. Remember, ultrasound is always operator dependent. In North America, ultrasounds are done by technologists, interpreted by the professionals, whether it is surgeon or the radiologist. But in experienced hand, once patient, the person knows how to perform it correctly. It has accuracy equivalent to MR, specifically in the early tumor, if it is like early, like T1, T2 disease. But it is not reproducible because the operator can be different in both of the situation. Here it is reproducible because it is dependent on the machine, not the operator. Field of view is so critical. For MR, there is no limit. You can extend the field of view as much as you want. On endoscopic ultrasound, it is a limited field of view. If the tumor is T3, you're going to miss. If it is more than 5 millimeter, you're going to completely miss the lymph nodes. You're going to completely miss the involvement of local organs if it is higher. If it is higher tumor, you're going to completely miss that, absolutely, because ultrasound cannot go there, endoscopic ultrasound. So MR is far superior unless the tumor is T1/T2. That is the only situation the endoscopic ultrasound is going to help you, or it will be comparable to the MR. So if you have a high stretching lesion, you can find better on the MR. If you want to assess the CRM, it will be better on MR. If you want to see the extramural venous invasion, that will be better on MR. So MR is superior in every manner except the T1, T2 disease. And that is the only indication, in my opinion, with a trained operator. Again, that is a caveat there. Okay. So our role is to determine whether the CRM is involved or not, whether tumor or deposits or lymph nodes. I mean, that lymph node kind of concept is gone nowadays. But if you have a tumor within 1 millimeter of the mesorectal fascia, that will be called as involvement of the mesorectal fascia. If the tumor is reaching between 1 to 3, and some people say it's 1 to 5 millimeter, that will be called as threatened fascia. And if the tumor is not reaching within the 5 millimeter of the mesorectal fascia, that is completely spared fascia. The threatened versus involvement depends on the number, how far the tumor is reaching from the mesorectal fascia, 1 millimeter, 1 to 3 versus 1 to 5, depending on the surgeon you are dealing with, because it matters what surgeon thinks in your institution. If the surgeon is taking the 5 millimeter kind of cutoff, stay with that, follow that, because that is how they're going to treat the patient. You're concerned about your own institution's therapy, not outside that. Then we have to determine whether it is T3 versus T4. And if the tumor is arising below the level of levator ani, that will be a low rectal tumor or anorectal tumor. So that will be having a different kind of approach for the treatment purposes. And then we have to see extramural and venous invasion, lymph node invasion, and peritoneal involvement. And as I said earlier, T3, bad T3 at presence of lymph nodes is going to be an indication for neoadjuvant chemotherapy. And they have to repeat the imaging after that. Repeat imaging has a different kind of interpretation because DWI doesn't work well there. It may or may not work. We have to give contrast in that situation always. but that is a kind of different topic altogether. As I said earlier, T2 are our workhorses. They are usually taken along with the long axis of the rectum with high resolution images, high, you can say, low FOV images, with thin T2 weighted images. That is why they are called as high resolution images. So they are thin, they are low FOV, and they are giving you better spatial resolution, and they have uh, better details of the tumor on these images. And we are taking all these sequences perpendicular to the long axis of the rectum, not the pelvis. You can add the pelvic images as well, that is fine. But our workhorse is going to be these T2-weighted images: coronal, sagittal, and axial, three planes, high resolution, along with the long axis of the rectum and the tumor. There is no bowel preparation required. This is all kind of older timer thing. With the newer generation MR, we don't need any insufflation. We don't need an endorectal coil. We don't need ultrasound gel either, because some people say that we cannot differentiate between T1 versus T2. We don't need to. It's not required because it's not a critical thing for the surgeon. We don't need ultrasound gel. We don't need antispasmodic agent. I mean, I have been on the disease focus panel of SAR for long. Actually, I was the one uh, in the beginning in 2016. We were just like 4 or 5 people who started this. Now there are more than 50 people, I think, on that forum. I led that forum now, but we have a consensus now. There is a guideline from the SAR DFP talking about what to do and what not to do, and what are the universally accepted protocols and what are not. Same thing applies for the IV gadolinium. In my opinion, it might help you in 1 out of the 10 patient or 2 out of the 10 patients, but once it does, it is going to be very critical. So you should give IV contrast even for the baseline scans. But many places are just doing T2 weighted images, and that works fine. I mean, as I said, 1 out of 10 versus 2 out of 10, that is the best possible changes you're going to make. But the point is, if the tumor is low lying, if it is T4, if you want to see the vascular invasion, then IV gadolinium is going to help you. This is how you focus your search. You're trying to find the tumor which is involved in the submucosa and the mesorectal space. You're looking for T2 weighted hypointensity surrounding it. That is muscularis propria. If the tumor goes beyond that, that will be called as T3 tumor. So here, if you see these discontinuities along with the muscularis propria, the tumor is going beyond that. That is basically T3 tumor. But the point is, sometimes the desmoplastic reaction can coexist with the tumor and can mimic it on MR, and you overstage it. It can happen. But in my opinion, after speaking to many surgeons, those are doing it thoroughly for years, overstaging is fine. If you overstage it and they slightly overtreat it, that's okay. But if you undercall it and treatment is not done properly, recurrences and residual tumors are not good news for anyone. This is the tumor which is lower rectum involving the levator ani muscle. This is the mesorectum we can see all together. And this tumor is looking slightly brighter than the rest of the rectum is. If we compare this T2 weighted hyperintensity with the fat in the mesorectum, the tumor is actually more hyperintense. And the bulk of the tumor, more than 50% of the tumor, is brighter than the fat is. So that means it is a mucinous tumor. You can determine whether a tumor is mucinous or not. And then you have to measure how far the tumor is starting from the anal verge. And you have to follow the angulation or the axis of the rectum. You cannot just measure from here to there. That is the wrong way of measuring. Okay. You have to follow the curvature of the rectum to get the exact number. In this case, it will be about almost like 6 or more centimeters from the anal verge. That means it is a middle rectal tumor. Vascular invasion is a very critical new concept coming nowadays. It is called as EMVI, extramural vascular invasion, and tumor involving it is not a good news, because these patients will have bad prognosis despite the best of the treatment, because there will be early chances of microscopic metastasis in these patients. Tumor can come back even after the treatment, either locally in the surgical bed or inside the lung or liver afterwards, mostly in first 3 years. But how you can determine that? If you see the tumor intensity inside the neighboring vessels, which is kind of nodular, that is basically EMVI. But it is not a condition to be called as EMVI that tumor is contiguous with the vessel. You can have a non-contiguous tumor and the vessels, and even though vessels are involved, because it is the drainage pathway of the same tumor. You can have inferior mesenteric artery or its branches of superior rectal artery involved by the tumor, even though the tumor was not contiguous, and that can happen. And that usually happens in T3 tumor. Seeing EMVI is a sign of T3 tumor. T2 tumor will never do that. And seeing involvement of like a nodular structure in multiple contiguous plane is a short sign that it is a vessel, not a lymph node. Lymph node will be seen in only one or two planes, not all of them. Okay, so make sure that you see that continuity of the nodularity throughout in at least 3 or 4 planes back to back. If it is situated in just one plane or two planes, that means it is a lymph node, not a vessel. Nodularity and the intensity are the most critical thing. And if you give the contrast, the behavior of the vessel compared to the tumor is going to determine whether it is involved or not. This we discussed already. And again, I said proximity is important, but not contiguity is not important. Desmoplastic reaction can sometimes overstage, but that is okay in my opinion. And it is sometimes very difficult to differentiate desmoplastic reaction from the tumor. DWI might help, but not always. What about the suspicious lymph nodes in the mesorectum? If you have any lymph node which is more than 9 millimeter in size in the short axis, that should be taken as involvement of the lymph node. If the short axis is measuring between 5 to 9 millimeter, you should have at least all of these three features, basically like speculated margins, shape is ovoid, and then you see heterogeneous T2 intensity inside the tumor. It's not absolutely black. It's kind of heterogeneous T2 hyperintense inside some of the foci is distributed. If you see all of these three signs in a lymph node which is measuring between 5 to 9 millimeter in the short axis, that is basically involved. Sorry, I said irregular margins, ovoid shape, and the heterogeneous intensity. That is for the 5 millimeter or lesser. All three should meet in 5 millimeter or lesser. Between 5 to 9 millimeter, it should be just two of them. My bad. Let's move forward. This is we already discussed. And yes, this is important concept here because if the tumor is draining to the vessels, those are anticipated to drain like internal iliac or superior rectal artery, which goes to the inferior mesenteric artery. That is the anticipated territory of the tumor, depending on the location of the tumor. But if you have involvement of the external iliac or inguinal or femoral region or common iliac region lymph nodes, that is not an expected drainage. That is all outside the drainage, and that will be called as M1 disease. If you notice, I did not talk about obturator lymph node. I did not say obturator is an extra mesorectal disease, because obturator will be, though it is not anatomically the drainage of the rectum, but mostly obturator will behave like internal iliac. So that will be taken practically as the mesorectal or locoregional, I would say, not mesorectal, locoregional disease on practical purposes. So if you have the tumor surrounding the rectum in the mesorectum, if you have tumor implant in the lymph nodes of the internal iliac region or obturator, this will be all called as locoregional disease. Anything common iliac, external iliac, femoral, inguinal, that will be called as non-locoregional disease. And that should be very critical. If you have lymph nodes in the para-aortic region, that is also M1 disease. And this is kind of still evolving, but just to give you a quick idea, people are doing it. USPIO kind of ferromagnetic agents, supraparamagnetic iron oxides. If you give them, they will be taken by normal macrophages. But if the tumor is present inside the lymph node, that will be not taken by the macrophages there. So if it is taken by the macrophages in a normal lymph node, that will look black. But if the tumor is present in the lymph node, it will be not taken by the macrophages, so it will look just white. So actually, you can differentiate between involvement of the lymph nodes by giving USPIO. It is interpreted after 24 hours usually. And and implants like lymph nodes up to just 2.5 millimeter can be characterized by giving USPAO. But this topic is under evolution still. And what about these tumor deposits? Tumor deposits usually occur outside the territory of tumor, like beyond the margin of the tumor, but they will be usually inside the mesorectum, and they will be usually along with the vessels most of the time. Okay, so presence of implant within 1 millimeter of mesorectal fascia will be still called as threatened mesorectal fascia or CRM. Presence of lymph nodes nowadays not taken as, because there are new concept coming now. Earlier it was. The presence of implant within 1 millimeter, presence of tumor within 1 millimeter, presence of EMVI within 1 millimeter, all will be called as threatened fascia or threatened CRM. So this is how the different T stages occur, or they look on MR. This is kind of early stage, the tumor situated inside the lumen. Here the ultrasound gel was given because we knew that it was early tumor. Tumor is confined to the submucosa. Musculus propria is well intact. So these are all kind of early T1/T2 tumors. Doesn't matter. As the tumor goes beyond the musculus propria, it will initiate some kind of desmoplastic reaction as well, and these are possibly presence of the tumor beyond the musculus propria. This will be T3 tumor. Depending on this distance, it will be called as bad or good. 5 millimeter or lesser is good, and 5 millimeter or more is going to be bad. As I said earlier, presence of tumor within 1 millimeter of mesorectal fascia will be called as threatened. Within 5 millimeter, it will be called within 1 millimeter, it will be called as involvement. Within 5 millimeter, it will be called as threatened. And then here we can see involvement of the tumor going beyond that, involving the vessels. Those are looking nodular in outline, showing intensity of the tumor inside the vessel. That will be called as EMVI. Presence of EMVI again within 1 millimeter will be called as involvement. Within 5 millimeter, it will be called as threatened. And remember the concept of bad T3 versus good T3. That is critical to remember. A, B, C, D, T3 is kind of your wish if you want to opt in your report. Involvement of the organ we talked about, T4, involvement of the tumor, which is abutting the wall, loss of intensity between the two. And once you give the contrast, here it looks like just abutting, but as soon as you give the contrast, you can see the enhancement of the tumor along with the posterior wall of the uterus. That is complete involvement of the uterus in this case. That will be T4 disease. Here you can see on the axial plane, the tumor is involving posteriorly presacral space, and we have lost those T2-weighted hyperintense vessels in the presacral space. That means the mesorectal fascia is gone already. And on the other plane, we can see the tumor is involving the uterus. So it is T4 disease. Doesn't matter whether it is involving the presacral space or not. Involvement of the tumor, even the musculature or the bone, will be T4 disease. That is the kind of misconception I've seen many reports, people not calling them, which is incorrect. Involvement of the musculature as well as the bone or presacral space will be called as T4 disease. Okay. This is how good we perform. Our negative predictive value is much higher compared to the positive predictive value or specificity or sensitivity, but our overall accuracy is in the higher 80s or early 90s. So we are doing good job. As we are better trained, we have better equipment. Our report should include all the tumor from the anal verge, distance, how far does it go, if there are satellite nodules or deposit within the CRM. There is actually a report template generated by us on the SAR web pages. If you go, it is free of cost. It is freely available to the public. It is called as template, or you can say synaptic reporting. You can download it from there, put it in your system, follow that tentative reporting, and you are not going to miss any important concept which is required by the surgeon. So if you follow that scientific reporting, you're not going to miss any of these points which I'm going to discuss here. And this is the scientific reporting. It is like it was done in 2021. I think I don't know whether they revised it or not, but this is how you're going to follow them. If you follow each of these points, you're going to include all critical points important for the surgeon. Let's quickly deal with 4 or 5 cases, and then I will be ready for the QA. So here, case 1, where is the mass and what is the T state based on the imaging? So if you look carefully, pay attention to the black line, and that is basically musculus propria. Some mucosa here, tumor situated along the posterior aspect, all confined, not going beyond the musculus propria. So it is early stage T1/T2, looking like T1 though, but on MR difficult to tell unless you have ultrasound gel given or endoscopic ultrasound performed by somebody. And it was actually T1 and N0 disease confirmed. This is case 2, where the tumor is first of all. And then it is rectal tumor or anorectal tumor. If the tumor is situated within the anorectal junction, that will be called as anorectal tumor. And then you have to talk about the distance from the anal verge, whether it is low rectal or not. So in this case, tumor is situated along with the posterior aspect of the lower rectum, because we can see it is going beyond the extent of the anorectal junction. So this will be called as anorectal tumor, posterior wall, T2 weighted intermediate. So don't call it hyperintense, it is intermediate. Then you have to talk about the distance from the anal verge. This thing, what you are seeing is basically the external sphincter, subcutaneous portion, so don't count it. From here, you're going to measure it, and that will be distance from the anal verge. And again, follow the curvature of the rectum, not go straight, okay? So yeah, it is all confined to the musculus propria based on the post-contrast images, and it is low rectal N2 tumor. And it was proven adenocarcinoma, that's why it was called as rectal. But the point is, if the histopathology was actually squamous cell carcinoma, this will be called anal canal tumor. Here, the tumor is situated in the middle rectum, and you can see it is situated going higher. See, this is the male patient prostate. You can see the tip of the seminal vesicle. This is the potential location of the peritoneum. So tumor is potentially situated at the location of the peritoneal reflection. Now the point comes whether it is T3, which we can see it is T3 most likely. It is going beyond the musculus propria in this location. But is it involving the peritoneal reflection or not? Because it's going to upgrade the tumor to the T4A. So that is the critical thing, because most of the tumor is situated on this side, on the left side. None of the tumor is reaching to the midline. The outline of the peritoneum is kind of well defined, smooth, not irregular. So that falls into T3 tumor, not T4A, based on the imaging. But it will be very tough. But it was actually T3 tumor. Another similar patient, higher rectal tumor, anterior wall. See, this time there is kind of different kind of intensity, and it's kind of more thicker at this location, thinner later on, and there is a small pocket of the fluid surrounding it. So seeing a pocket of fluid near the tumor insertion of the peritoneum and peritoneum looking irregular thickened is a sign of involvement of the peritoneal reflection. Even in this case, we are not convinced that it is going beyond the musculus propria. So even though tumor is not convincingly seen beyond musculus propria, it will be still called as T4B, T4A tumor, sorry. In this case, actually, there was a metastasis in the liver. So as I said, whenever you have EMVI positive, whenever you have peritoneal reflection involved, tumor can metastasize earlier. Another case, mid-rectal tumor, kind of causing a little bit of stretching there, but tumor is going more along with the anterior aspect, and mesorectal fascia is situated anteriorly here, which is very close to the infiltration here, almost kind of within few millimeter. We have to measure it, whether it is 1 millimeter, then it will be called as involvement. And once it is within 1 to 5 millimeter, it will be called as threatened. But as I said earlier, this mesorectal space becomes very smaller anteriorly as we go lower. Despite it's an early, not bad T3, but it can still invade the mesorectal fascia and the CRM in this location. Okay, so one more case. I'm glad we have this one. Okay, this one is critical because it can be missed by anybody, including myself. So what will happen here? See, this is the same thing happening. We have a tumor which is going anteriorly, involving the mesorectal fascia, very close to the CRM, as we saw in the other case. Perfectly looks T3, bad T3, obviously, much more beyond 5 millimeter or more. Bad T3 disease, potentially threatening the mesorectal fascia, if not invading. Maybe part of that is dysplastic reaction as well. But what is going on here? The lymph node, which is looking ovoid, which is looking heterogeneous, which is looking like irregular in outline. So this is possibly involved. The short axis is going to be 5 mm or more. So we just need to meet just two criteria. But what is happening here? There is a lymph node in the external iliac region. So if you just focusing on the mesorectum, you're going to miss the findings somewhere else. So this lymph node in the external iliac region is going to upgrade the disease to M1. BAT T3 N2 with M1 disease in the external iliac region. So we have to do a surveillance based on the pre-treatment, you can say, risk. Patient with LAR in the low rectal tumor, preoperative CA more than 7.5, Duke C stage, basically it is presence of lymph node in the vicinity of the tumor, poorly differentiated carcinoma, mucinous adenocarcinoma, because they don't respond to the treatment very well. They have high recurrence chances. They all need intensive follow-up. Everything else will fall in the low risk. And based on that, high risk versus low risk, you can decide what kind of surveillance you want to do. Most of the people are doing MR for the surveillance as well. And then they do CT abdomen pelvis or chest CT abdomen pelvis, depending on the pre-staging involvement of the chest. Recurrences are mostly in the tumor bed. They usually occur in first 3 years. And then, unfortunately, if there was presence of EMVI or peritoneal reflection involvement earlier, chances of having recurrence in the lungs or liver are higher. Role of MR will be remaining always very critical even after treatment. After the treatment, bit different interpretation. You have to give IV contrast. DWI will not work well. I did not discuss DWI much in this case because T2 are the mainstay. For the purposes of extent of the T3, good T3 versus bad T3, and the lymph nodes in the baseline scan, DWI can work very well. It can be a complementary image, but not the mainstay image. Same thing applies to the post-contrast images. Those are critical, but not important for baseline. In conclusion, we have evolved a lot in the last 2 decades, and MR has become the modality of choice for rectal cancer staging. And as we learn more, it is becoming more adopted by practices in the community hospital. And it is giving the best possible success to the surgeons and the best possible treatment to the patients. So let's spread the word, teach the next generation, your colleagues, learn it better. There are lots of stuff available on the internet nowadays. Our aim here is just to spread the knowledge and provide the best possible care to the patients. This is my book, which has this first chapter, my favorite in this. I think this particular topic, at least few chapters are freely available on Google Books. If you go there, just open the Google book and see what kind of free content is available. There are a few chapters, those are free. I think this chapters might be free there. Try, and if you read it thoroughly, you will get better information what we discussed today. And I have included lower rectal tumor, anal canal tumor, mucinous tumor, and the recurrences after the treatment has been given on how to interpret after treatment scan in that chapter with some very good cases. So it will help you. I'm ready for any questions.
Okay, I'll just look at the Q&A box. We have 2 questions.
Okay.
The first one is one of the attendees is asking how to identify the anorectal junction on MRI.
Yeah, that is the same thing I discussed in the beginning. So you have to just follow the puriclis muscle and the insertion of the levator ani muscle on the posterior aspect of the rectum, and where it merges with the puriclis muscle and the external align sphincters. That is anorectal junction, surgically and on MR.
Okay. We have a second question about case 1. They just wanted a quick review, I guess, of it again.
Okay.
Yeah.
Case 1, let me see what is that? Case 1, like in the
sample case.
Is it coming? My screen is coming or not?
Still loading.
Okay, maybe I don't know what's going on. Let's try one more time. Is it now there? Can you see the screen?
No, it's just showing the question. Okay, it's now okay. And scrolling now, yes.
Case 1 of this one, or
yes, that
okay.
one. And case 4. So they ask specifically 1 and 4.
Okay. What's the question here?
I think they just maybe they didn't understand.
Okay, sure, no problem.
Yeah,
so if you pay attention, we are at the almost at the bottom of the mesorectum here, because we are seeing the musculature surrounding the rectum, because we are at the bottom. It's lower 1/3 of the rectum. And if you pay attention, there's kind of black line surrounding it. That is musculus propria. Another black line inside is basically the mucosa. Okay, and this space in between the two black lines is basically submucosa. Tumor is situated along with the mucosa mostly, so not even involving the space underneath the mucosa. So that should be an early grade tumor, usually T1, but sometimes it's very difficult to differentiate between T1 versus T2. If you call in a report T1/T2, it's also okay on MR, because that's not going to change the treatment part at all. It can be still operated via transanal resection or excision surgically. And depending on the post-surgical pathology, they can decide if they want to treat the patient or not. But seeing a tumor not going to the submucosa is a very good sign, and you can confidently call as T1/T2. And case 4, you said?
Yes.
Yes. So case 4 was like a buddy case of case 3. The difference between the two cases is basically you are seeing the tumor involvement anteriorly, same way the case 4 is doing. And here we can see the tumor is going beyond the musculus propria. So we can see like a hazy kind of linear extension of the tumor inside the peritoneal space here. So it is obviously a T3 tumor, looks like a bad T3 rather. But the point is, we are seeing it is situated very close to the peritoneal reflection. But peritoneal reflection in this case is kind of very smooth. It's not like irregular, thickened. So it's kind of very controversial, honestly. Many experienced people is going to call it T3 disease, and some people will overstate it, call it like T4A. As I said, if you have a doubt, go a bit higher, step higher. If you call it T4A, it will be slightly more treated than expected. In this case, not going to change the management surgically, like APR versus LAR. So it's not going to compromise the patient quality of life in the longer run. Maybe it's just kind of more you can say treatment days, or slightly more aggressive treatment. But this was actually T3 tumor, because the peritoneal reflection is kind of smooth. In case 4, despite the tumor looks like very much confined to the musculus propria, the black line is confining the tumor, except some of the portion maybe. But this particular reflection look kind of irregular. It's kind of thickened, and there is presence of a pocket of small fluid. So fluid usually occurs in response of some kind of reaction, like something happened, which is causing kind of edema leading to the fluid formation. And that usually happens once they have the tumoral cells in that area. Even though MR cannot find, you can say, cytological or histopathological invasion, the presence of the fluid is a sign of edema and kind of the reactory process going on in that location. And then we are seeing some kind of thickened peritoneal reflection, which is kind of irregular here and becomes thinned out afterwards. So that is a sign that's possibly involved. If you call it T2, it will be a kind of catastrophe for the patient. It has to be called as either T3 or T4. It is T4A based on this appearance. That is what I'm trying to communicate in this case.
Personally, I had just on my side, I had a case of a patient come in with complex perirectal abscesses in like de novo, and they were drained multiple times, and they couldn't identify
the cause.
they couldn't identify the cause. It was coming back as like repeated infections, but then later on they came with metastasis. It was actually rectal cancer. So how do you confidently able to differentiate?
See, in the beginning I told you there are many things which can mimic the cancer and look like same. Unless you have suspicion, you're not going to call them. Same thing applies to Crohn's disease. Crohn's disease is maybe not that common in that part of the world, but very common in North America, and it looks like cancer in many cases. So the first prerequisite to perform an MR for staging purposes that you have a biopsy proven cancer. If you do not have a biopsy proven cancer, things can become very complicated and go downhill, because cancer can perforate. Cancer can perforate and cause formation of abscesses, and abscesses will further complicate because it will lead to edema, same way which happened in this case. If you have edema, it is very difficult to differentiate which part is inflammation and in which part is cancer, even with the contrast has been given, even if you use DWI images. So having a baseline before the cancer started or the cancer was perforated, I would say, is very critical to compare with, and then see the evaluation of that tumor over the period of maybe a few weeks. If you have high suspicion that it can be a perforated tumor, honestly speaking, abscess will never have an enhancing nodular component along with the wall ever. It will all have inflammation surrounding the rectum, and the collection, which will not enhance on fat suppressed subtraction images. Okay, that is the key. So use fat subtraction images, fat suppressed subtraction images for the determination of enhancement pattern always. If you see an enhancing component along with the wall, that is a suspicious feature. You should move to a close follow-up in about 5 to 6 weeks after the antibiotic treatment and drainages. If that persists there, you should alarm the surgeon to go inside and take a biopsy from there and say it can be perforated tumor.
Okay. Thank you for the answer. We have another question.
Sure.
How sensitive can you be when you, like, can you determine staging using contrast CT? Like,
No.
okay.
Never do or never try. You will never be successful. You will always understage the disease. Never do.
Okay. And the last question, I'm not sure if we have do you see any cases in your experience that were very tricky mimicking cancer, rectal cancer?
Yes, many cases are there. I've seen personally many patients where surgeons were very, very enthusiastic. They did not even biopsy or endoscope the patient and then send it for the cancer staging, assuming that it's going to be cancer, and they were not cancer. And most common was actually Crohn's disease in our patient population. I mean, I've seen at least 4 or 5 cases where I put disclaimer after those cases. Actually, I put a disclaimer: this is not a biopsy proven. It is a presumed cancer. Assuming it is a cancer, the stage is this. If it is not cancer, it can still be inflammatory disease, like Crohn's disease. As you already mentioned, you can have perirectal abscesses because of some other reasons. So you can have high perianal fistulas, which can mimic like a abscess and lead to inflammation. But the key is your experience and the way you interpret the images. You should follow the evolution on pre-contrast T1 and then see those cases on T2 weighted images and then correlate after the contrast has been given in fat suppressed subtraction images and correlate that finding with DWI. This is how you evaluate step by step. And I'm telling you, if you follow these sequences step by step, you will possibly differentiate whether it's real tumor or not.
Okay. Sounds good. I think we have no more questions.
Perfect.
Yeah.
Appreciate everybody coming here and spending your time. I'm confident that it will help you in your practice. If you want to learn more, go through that chapter. As I said, it might be free of cost to everybody. Try that. If you have any question, just email me. I'm ready to answer anything.
Okay. Thank you very much for the presentation.
I'm honored to come here, and thank you for inviting me.
Yeah. Okay.
Thank you.
Thank you so much. Yeah, thank you so much, Dr. Lalwani. Thank you so much for such a wonderful, very illustrative. And you had the graphical image, the MR image, and some of the correlates with the biopsy and ultrasound. Thank you so much for having, for doing such a wonderful lecture. It's
Thank you,
very
JP. Thank you. Thank you.
Thank you, sir. Thank you.
Bye-bye. Bye-bye.
All right, thank you. All right, so this is it for our abdominal session. We're done with the abdominal session. We're going to be starting with the musculoskeletal session for the next time. But we have a quiz question. So can we get the quiz question for the day, please? And I also want to thank Dr. Mohammed Warfa for moderating this session. Thank you so much, Dr. Warfa.
Thank you so much, JP.
Thank you.
Yeah.
So this is the question. You guys have 2 minutes to answer the question just because of the just to be respective of the time. So what T stage is this rectal cancer? So you see the image there. It's a sagittal image MR. What T stage is this rectal cancer? Please use the QR code and then answer the question using the QR code. Please do not post the answers on the Q&A or the chat box. So is it stage 2, stage 3, stage 4A, or stage 4B, T4B? So option A is stage T2, B is T3, C is T4A, D is stage T4B. So what T stage is this rectal cancer? You have 90 more seconds. Please scan the QR code and answer the question, please. For the last 60 seconds. Got last 15 seconds. All right. Can we get the answers, please? So the answer would be option C, stage T4A. As you guys see here, this is a lateral image, like a T2 image, MR. You see, this is all these are tumor, but the arrow is pointing towards the tip of the seminal vesicle where there is peritoneal reflection. So this is involvement of the peritoneal reflection, as Dr. Lalwani said. So that would be at stage T4A. So the option C is the right answer. All right, thank you all for attending today's session. And we can have the QR code for the survey. Please complete the survey to receive a certificate. So attendees who complete the survey would get a certificate. And please remember to attend the next session, which is the musculoskeletal sessions. We start musculoskeletal from next 2 weeks from now. It's July 21st, and that's imaging on inflammatory arthropathies from Dr. Maha Torabi. So that's on 21st July, Sunday, same time at 9 a.m. Eastern time at the US. So thank you so much.
I have
Please,
JP, I
please.
have a one quick announcement.
Yes,
So
ma'am.
for next Sunday for residents and trainees, we will have a case conference. If you have time, Dr. Saga Armin from Emory University, my colleague from Emory, will share his cases with us. There will be a lot of fun cases. I already sent out the invitation to your residents email. email. So please check that. And if you have time, please join. If you don't have time, that is perfectly fine. It's going to be a fun session. Thank you.
Thank you, Nat. Yeah, those are always fun and great cases. So please, the residents, please try to attend those sessions. All right, thank you so much. Thank you, all the attendees. Thank you, all the committees and the IT team, especially for doing such a great job. And thank you, Dr. Warfa again, and thanks all the panelists. Thank you, Nat. Y'all have a great week.
Thank you. Enjoy the rest of the weekend.
Thank you.